So it is my pleasure to start with our panel discussion today. The goals of the panel were to showcase some of the existing projects that are happening in the Mississauga, Halton, Lynn, and beyond, and highlight some local health equity champions. Here we go. There are many very interesting health equity projects happening in the Lynn, and we do recognize that. Unfortunately, we can't highlight all of them for you today, so we have given you a sampling of some of the great work that's happening here. In the interest of time, the organizers are suggesting not to field any questions from the group. Of course, again, through many of the networking sessions that we're going to have starting after the panel with lunch and throughout the afternoon, there will be opportunity for you to ask your specific questions to the panel. But at this point, we are going to just go through an opportunity of each of the panelists to give us a brief presentation, and then we do have a series of questions that I will ask them and give them the opportunity to respond to. So without further ado, it's my pleasure to introduce our panel. I'm going to start with Erica Norris at the far end. Erica is a registered nurse and works as a public health nurse with the Halton Region Health Department. Her work is focused on the social determinants of health and health equity and supporting efforts to improve the health department's capacity to address health equity. In her presentation, Erica will talk about different strategies to strengthening capacity to address health equity. Sharon Douglas, beside Erica, is the Director of Community Investments of United Way Peel. She is particularly interested in issues of accessibility and integration as key components of health equity. In her presentation, Sharon will talk about what it looks like when health equity is introduced into funding streams. Marcus Logan is the LGBTQ Education and Support Coordinator for the Positive Space Network of Halton, based out of the Reach Out Center for Kids, and advocates for positive mental health and well-being for the LGBTQ population in and across Halton Region. In his presentation, Marcus will focus on access to healthcare and the potential barriers for LGBTQ+ and trans communities. Welcome. Lisette Figueredo is the Manager Accessibility and Diversity at Trillium Health Partners, and Lisa Rolfsima is a social worker at the Supportive Care and Psychosocial Oncology Program at Trillium Health Partners. In their presentation, Lisette and Lisa will focus on language issues as a means to equitable access to care and inclusion. This will also touch on ASL, American Sign Language, and health literacy. They will then build up on these from a clinical perspective and collaboration of services. And finally, to my left is Baldev Muda, who has been in the field of social work for the last 30+ years. He is the founder and the chief executive officer of the Punjabi Community Health Services. In his presentation, Baldev will address why cultural competency is important and the need for cultural, ethnic, specific healthcare services. Please join me in welcoming the panelists. So I started at the end, but the mic is on this side. So we're going to start with Baldev with his 3-minute presentation. Thank you, Baldev.
I'm going to be elaborating just 3 points, 1 minute per point, so that I can stick to the 3-minute agenda. One is we exist to provide culturally appropriate services. What it means is that we understand what the specific needs of the culture are and how we tailor make our interventions to based on those cultural needs. So if you look at the South Asian communities, we understand through research that we have a higher rate of heart disease, we have a higher rate of diabetes, we have a higher rate of addictions, and we have lower cancer screening rates. We know from evidence. So the question for us becomes is how do we address those within our intervention? So that's why we exist. The second one is we always talk about client-centered approach versus agency-centered approach at our agency. In order to enhance access, we open 24/7. Our major group programs are done in the evenings or on Saturdays and Sundays. The rationale for that is that our communities, predominantly in Brampton and Malton, are newcomers to Canada. They work at different hours. It's very difficult for them to come during the daytime, so we make sure that they come on weekends. So our staff is staggered and they work all during the Saturdays and Sundays as well. In addition to enhancing the access, we make sure that our staff is mobile, they have laptops and they have cell phones. They do not need to come to the office. They can meet the clients at any given time, at any given way, wherever they want to. The third one is in terms of when we determine what client-centered approach is, it doesn't really matter what we believe in. It's what the client determines the outcome to be. So it's very client-centered. Client determines. One such example is that our culture is very narrative. They like to tell stories. It's very difficult for us to get a yes or no answer from them or very quick. So our single assessment for an addiction takes 3 hours. Any counseling session that we do, whether it's with abused women or whether it's with the men who drink too much or whether they have any other issues that we do, the minimum counseling sessions are 2 hours in length. So we understood what our cultural needs are and we tailor-made our interventions based on it. The third point that I'm going to talk about is if we look at cultures, we really need to understand how they become sick and how they become healthy. If we do not understand why a culture becomes sick or what are the dynamics interplaying within that culture, we will never be able to address what the complexities of it are. And I think my 3 minutes are up. Thank you.
Oh, well, we're good. We're sticking to time here. Thank you very much, Baldev.
So I'm going to give you 3 scenarios. In each instance, the context is a person with English as a second language. So in the first scenario, imagine that you're being given a new cancer diagnosis, and the person giving you the information is a family member who is providing the interpretation. Now imagine that that family member is your child, and he or she is only 16 years old. In the second scenario, imagine that you actually speak English pretty well, so you don't ask for an interpreter and you're not offered one. You don't understand most of the medical terms that the doctor is using, but it would be rude to question the doctor, so you just sit there and keep nodding your head. You leave your appointment with some printed materials and a list of appointments that you'll be sure to keep coming and attending, but you still really don't know why you're doing these things. And finally, in the third scenario, imagine that your doctor tells you that the cancer isn't going well, but there's some problems that they can fix for you. This goes on for a while until one of the problems brings you to emerge, and the doctor there bluntly tells you, well, the big problem is that the cancer isn't going away, and you should probably start making some plans. So you and your family are shocked because you don't understand and didn't ask what it meant when the doctor said the cancer isn't going well. So in terms of our interpretation services at Trillium Health Partners, Lizette will speak more to that. I just wanted to give you a little bit more information about our efforts to promote health literacy. So in a medical setting, we tend to educate our patients. Often we do this. We tell them a lot of information, then we give them a bunch of handouts, we repeat the information, and then the appointment is over. How do we know that the patient has really taken in all of that information, absorbed it? Do we know what their learning style is? Do we offer them more than just verbal or written information? Do we ask them to tell us back, what did you understand about what I said? So almost 2 years ago, we hired an oncology patient education coordinator. And one of the things that she's asked us to consider is different ways in which people learn new information. So the same method of information delivery isn't going to work for everyone. Some will need written materials, some will need to hear the information, some will need to take the information back and reflect on it, and others will need to be able to interact with the information in some way in order to understand it and take it in. So the simplicity of language is also important. We use a lot of medical terms on a daily basis, and because we understand the term, we may not define what it means for someone and assume that they understand it the way that we do. If we're defining that term, do we define that first, or do we give them what the term means and then define it? Those are all questions that our patient education coordinator has worked with us on, providing information sessions so that we can better understand how to educate patients and take those things into considerations. And she's done that by providing a number of education sessions where we now look a little more closely at what are we providing, how are we doing it, and are we checking to see if that information is really understood the way that we want it to.
Over 20 years ago, when I started working in healthcare, I was asked at one point to interpret for a Portuguese-speaking patient. It happens that the patient was actually an employee of the hospital, was one of the porters that needed to go into a surgical procedure, and he had to be explained what he was going through. So he couldn't really understand the doctor without an interpreter, and that's why I was called. Now, to my surprise, was that this man it has been for the last probably over 20 years, the interpreter of the hospital for Portuguese patients. So my question is, what happened during those 20 years to all the patients that he did the interpretation? After that, and in getting more involved with what was going on, I found women that had gone through hysterectomy or sterilization and they had no idea what happened to them because the doctor explained, but they couldn't understand. So after all of this, I made it a bit my passion to deal with these issues. And interpretation and translation became my baby, if you want to call it that way. And I tried since then to implement these services in the hospitals that I've been working, and Trillium is not an exception. So I'll just tell you a little bit how the system works for us and the strategy that we got. Basically, you need to get people on board, hopefully. It takes some time and sometimes it's a bit difficult. We have a policy for language services that is also supported by our policy on consent for treatment. So no procedure is done without the use of an interpreter. We have a centralized services of language where that services the 3 sites of the hospitals. We provide interpretation in all the languages, including American Sign Language, which is our 4th highest requester for that language. We had so far over 1,500 interpretations up to February for this year. So basically, we require all our interpreters to have proficiency language tests. They have to be professionally trained and be certified. We also facilitate awareness within the translation. When we receive materials to be translated, we ensure that the material is already abiding by the health literacy guidelines, so that it's in simple language and is appropriate for our reading for the community at large. We also have to attend that 42% of Canadians in general don't have low literacy skills, so this is not targeting only the ethno-specific communities, but the Canadians in general. Am I good?
This is really hard, I think. It kind of feels a little like the Oscars again. I keep referring to the Oscars. But, you know, when the music, it's a sign instead of the music playing. I think when he starts to stand up, then you know the music's playing really loud. But it's really hard when you're so passionate about a subject to shorten it to 3 minutes. So I think we have a little bit of time. Yeah. So
I can hear Felix's beeper going off too. So.
I'm going to look this way.
I'm Marcus Logan, and I'm the coordinator of the Positive Space Network in Halton, based out of ROC, Reach Out Center for Kids, which is one of our local children's mental health agencies. And my program is a peer certification program for the Halton community. So I go into agencies. I currently have about 27 agencies that are involved in the certification program, and it involves 2 days of training. How to create a positive space in your workplace, how to be a better ally, and then Trans 101, some topics on trans and gender issues. On top of that, then the agency will go through a HR policy review with me to make sure that the language that they're using, the intake forms that you're using are inclusive of the LGBT community or aren't making them invisible or isolating just male, female, gay, straight, that sort of thing. And then the agency has a mechanism built in place that if an LGBT person, gay, lesbian, bisexual, transgender, or the queer and trans community, as it's now being called, has an issue in that agency, they are able to have a mechanism to report that to me or to my network, and then we can go back into the agency and work on that so that they can maintain the certification. We then assign the agency 4 or 5 goals that are to be achieved within the first year, 6 months to the first year, to maintain their certification. So addressing the health equity and healthcare access for the queer and trans community, I'm not a Toronto-based agency. I'm not the center of the universe. I work in Halton, and we're a very unique, different kind of community. And so the way that I'm addressing the health inequities for the queer and trans community is to make all of the agencies that serve youth and serve families and serve adults queer and trans positive, so that any agency can accept and he's making me nervous, can accept and really service that person to where they're at. I really want to speak today in my last 10 seconds really around the health inequity and the barriers to health care for our trans community. I have one doctor in Halton who will accept a trans client. He's full, he's busy, he can't accept anymore. So there are no physicians currently in Halton that can support a transgendered person through that process, hormone therapy, surgeries, whatever their needs are. So that's one of the barriers I'm facing here in Halton.
I'm going to look this way so I don't see you. So, hi, I'm Sharon Douglas. Good morning, from United Way of Peel Region. And I'm speaking about us incorporating health equity into our funding stream and making it a requirement of our funded agencies to be able to report back to us. About 18 months ago, probably about 2 years ago, United Way of Peel, and I have to specify of Peel, decided to take a hard look at our investment strategy and spent a whole year basically doing research, meeting with community partners, having focus groups, and trying to understand what were the most relevant, what were the topics now that were impacting our community. So after that process, we changed our funding streams, we opened it up, but one of the things that has always been extremely important to United Way has been the value and the commitment to equity and inclusion, but felt it was now a time to actually walk the talk. And so what did walking that talk mean? One of the connecting themes, or the primary connecting theme for United Way with our investment strategy, is poverty. When we looked at poverty as an overarching theme, the consequences and the impact of poverty right across all communities, populations, age groups, no matter where you were within the region, was evident. We wouldn't be able to reduce poverty, but we would be able to maybe reduce the impact on the consequences that poverty has on the populations. One of those things for the region of Peel, which is huge, is that the racialized communities, newcomer communities, seniors and women are more greatly impacted by poverty in our community than any other population group. So when we started to look at that, we thought, then what were the barriers? What were the issues? Somebody earlier today talked about stigma and looking at food insecurity and being able to address what were the key root causes of this poverty within our region. And how did that impact? And instead of putting a Band-Aid on that, let's go right back down and understand how this came about in our community. So our strategies changed, and I think Keaton referred to food insecurity, which is one of the strategies we have under our poverty to possibility. Where's Felix? Oh, okay. Poverty to possibility focus area. How did we address that? So this year we implemented for the first time asking our funded agencies not only to look at diversity, equity, and inclusivity within their own organizations, but look at collecting the data for racialized communities, newcomers, and refugees that access services through their own agencies, their programs, and their services. So we've just received the first 6 months of that data. Surprisingly, and we were excited to see and encouraged that many of our agencies were already collecting that data, but had never really been asked for it, and we're not really actually using a whole lot of that to sort of support their proposals or get more funding programs or more funding for their programs. What we've also decided to do, which was, I can't see if I have my glasses on, so I'm trying to read my notes without my glasses, so this will sound back and forth a bit. As a funder, we felt, and we're not the biggest funder in the region, but we feel strongly that we have the ability to influence and we have a responsibility to advocate for those who don't have a voice in the community, for those who aren't able traditionally to come to those tables, for those who historically have been marginalized and excluded from any kinds of programs and services within our region, and I can probably say across the GTA. The other aspect of that is that for many of our agencies, if not all of our agencies, they would say they have a diversity policy, that their organizations are representative, that their boards are representative, that clients from all walks of life come through their doors. But we still have stories, both quantitative and qualitative data, that says many residents within our communities are not able to access programs and services within the region. Thank you.
So I'm Erica Norris, and I'm a public health nurse with the Halton Region Health Department, and I work in the area of social determinants of health and health equity, and I'm going to say that it's a relatively new position that was established in 2011, and the purpose of the position was to enhance supports to address the program and service needs of locally identified populations that are negatively impacted by the social determinants of health. So these nursing positions do exist in public health units across the province, and everybody's using them in a slightly different way. In Halton Region, we had decided that where we could sort of get the most bang for our buck is to look at enhancing our capacity of staff across the health department to better integrate equity considerations into the work that we do. So I provide staff support to those initiatives. And most recently, there's been sort of three main initiatives that we've been working on. One of the first ones that we did was to establish a social determinants of health steering committee in our health unit. So that committee was chaired by our medical officer of health and had representatives from our senior management team. And the purpose of that group was to really provide the leadership and the strategic direction to move initiatives forward. And that's been really key and instrumental in helping to advance this work and this agenda. One of the next pieces of work that we did was to look at staff education sessions for all health department staff. So we looked at a social determinants of health and health equity 101, if you will, where we had an opportunity. It was created by our own frontline staff, a very multidisciplinary group. And it was an overview of health equity concepts, and it was also creating an opportunity for staff to begin to explore some personal values, beliefs, and biases that they might have related to different equity concepts. And that was really done in preparation for an initiative that we're currently looking at right now, which is beginning to explore the use of the health equity impact assessment tool in order to help us integrate equity considerations into our program planning in a more systematic way. And I certainly wouldn't say that we would be the experts in it, but definitely learning as we go.
Thank you, everyone. So as you see, we've got a great panel with a different cross-sectoral focus for each of them. So thank you very much for that really tough task of sticking to the 3 to 4 minutes for your presentation. I do have a series of questions and that I'm going to pose, and I know we're going to be passing the mic around just so everyone can hear. And perhaps what I'd suggest is if you just kind of signal to me, I think we can probably have about 2 or 3 responses to each question. We have a little bit of time, and then depending on how we're doing, I'll move us to the next question if that's okay. So again, we're just enjoying this nice fireside chat. So please, this is your opportunity to really tell everyone the great work that you're doing. So the first question that I have is, can you tell us how you went about identifying the particular equity issue or affected population your organization or project is addressing? Sharon.
I'm holding the mic. For United Way, we have 3 community advisory councils, and what that was based on at that time was solely the largest racialized communities within the region. So we have the Black, the South Asian, and Chinese communities, which are our largest segments of the population. What's coming up really quickly is our Latin American and Filipino communities. Once we determined that, we then started looking at what were the challenges, issues, and barriers faced by those communities. And as part of our work and our commitment to that journey of equity and inclusion, these communities are able, through the engagement work of their coordinators, to be able to bring forward to United Way what are the challenges at a real grassroots level that's happening within each one of those communities. And so this is how it was a census decision at one point.
So you talked sorry, I'm going to delve in a little bit. You talked about poverty and the focus for the United Way on that, and now you've talked about the different cultural groups. Are you finding that that's the same with each of those cultural groups? Or are you finding that there are different aspects that you need to address with each of those groups?
There are similarities, and then there are some things that, and there are similarities in different degrees, if you understand that. So for each one of those communities, the impact of poverty is greater than the majority. Well, it's no longer the majority of our community within the region appeal. But what we find that in the Black community, for racialized youth, let's say, the impact of poverty, the impact of underemployment and unemployment are greater than, say, within our Chinese youth population. And so what we're able to do through the community advisory councils is really delve a little deeper, go below the surface at understanding what is that impact. But poverty right across the board impacts all 3 of the populations. Does that answer your question? Mm-hmm. Good.
Thank you. Anyone else want to tell us how they decided to focus in on that particular topic? Lisa?
I think ours is mostly based on the patient feedback. When you run into some of the scenarios that I shared earlier, people don't like those things. So then they start saying, who can I talk to about this? And so that's where things start. And we now moved towards having an actual patient and family advisory council where we can be proactive. We can get engagement from the people who receive our services and then have them as part of our planning for what services we're going to continue to provide.
Thank you. Baldev.
I think the challenge is not in the identification of the problem. I think the problems have been identified since the Lalonde report in 1974. The challenge, however, is in finding solutions to these complex problems. I think as Canadians, we are so nice to each other that we never talk about the R world, the racism and the systemic racism that is inherent in institutions that is cause of some of these complex challenges. And I think if we continue to ignore these complex situations as to how we're going to talk about solutions, I think this will be another kind of a forum that we just talk about, okay, this is health equity, there is an impact assessment tool, but the complexity is how do we make changes in our own organizations to accommodate those identified communities within our communities that have difficulty accessing. So one such example is the LGBT community within the South Asian community and within my own organization. So when we talk about this complexity, the board became very panic-stricken when I raised as a CEO that we should be serving LGBT South Asian community. They said, oh, do we have one? So imagine the ignorance of this whole issue. So when we look at solutions, I think that's when all these biases and prejudices come up. They don't come up at the labeling of the problem. They come up at the labeling of the solution.
I think that's a great point and actually a great segue. into the next question, which really does delve into that. And as we start to come up with some of these solutions, or as you started to perhaps to identify some of your projects, were there other vulnerable or marginalized communities that experienced unintended results due to your program or project? So it's great to take that step forward, as Baldev identified. But then in doing that, there are communities or there are other groups that perhaps people didn't necessarily realize were there or were not necessarily prepared to address. So I'm wondering if any of you had similar experiences or are able to share on that.
So from my perspective, definitely, as Baljit has said, the intersectionality of sexual orientation and gender identity intersects with everything: poverty, food security, racism, all of those pieces. And so that has been, it's an emerging issue in Halton to try and deal with your faith and religion and your sexual orientation and gender identity at the same time. And how do we do that? The other population that I think has really benefited from the work that we're doing and being attached to our Children's Mental Health Agency is our young gender variant children and their families. So they now have access and trained therapists who can support a young child going through or experiencing their gender variance and growing up in a very positive, safe, and supported environment. So when I started this work in 1998, I was said, people would give me their kids and say, he just came out or he thinks he's gay, fix him. And now I'm getting, my child just came out or he experiencing some gender issues. How do I help him? How can you help me help my child? So that's been a really great benefit.
Okay, thank you. So my next question is getting into a little bit more of the tactics. And I'm wondering if you'd like to address or tell us, how did you identify ways to reduce potentially negative impacts for marginalized or vulnerable populations? And that includes clients, staff, or funding applicants.
United Way as a funder is in a really great position because we have community partnerships and stakeholders, and we have corporate partners and relations there. So what we had the opportunity to do was begin to have that dialogue. We see ourselves as a community impact organization, as a convener of community members, as somebody who's able to facilitate conversations and dialogue. Once internally we were comfortable and understood as much as we could where we were at that point in time, the impact and the issues of racism and the consequences of poverty and the impact of discrimination, not just through our clients and the funded agencies, but our own relationships. What did that mean for us? And so it was a matter of creating the community advisory councils, which was a whole lot of public awareness, but it was taking a real public stand as a funder and saying, you know what, racism exists. It is one of the determinants of health. It has an impact on people in our community. And if we are going to achieve our mission, then we need to stand up and say something. It was a huge step for United Way. It was a risk for United Way because we're totally dependent on donor dollars in order for us to survive. And we weighed the pros and cons. If we were here to serve the community, and this was our reason for being, then at some point we had to put a stake in the ground. And so it was having the conversations and creating the spaces for those conversations and being a leader in saying, we are willing to walk the talk. And I think for us, that's what has worked so far.
And just to tie into what Sharon said, I think it's those dialogues that are really important. There's not a lot of evidence out there about solutions, and so what we found is that if you can bring a group of people together to have some discussions, that's where you can really get some great think outside of the box ideas, and we can be creating that evidence as we go along by telling the stories, because it's at this point I think there's a lot of maybe promising practices at best.
One of the ways to get some good feedback from the community is through community engagement sessions. I think that each one of your agency must be doing some kind of a community or consumer consultation. But what I have experienced is that once we do our community engagement or community consultation, we get wonderful feedback, but it never goes anywhere. So one of the ways to make sure that at our agency, that when we get community consultations or consumer input, we make sure that it is posted on the wall in front of the CEO's office. So anybody who walks in actually knows that these are the issues that we are confronted and that this will be implemented, and then it's conveyed to the board, the resources are allocated. Otherwise, the community consultations will never be really community consultations, because people become tired of giving you ideas when they are not being implemented. I think the community consultations and engagements are the best way to, and that's what the United Way did, United Way Appeal. And I tended to support Sharon because their community consultations led to this giant reorganization. And had they not done it, she would have had an earful from me.
So all of you had an opportunity to showcase the different approaches that you've taken, or the different populations that you're focusing in on. I'm wondering, and I'm going to ask perhaps all of you to comment on this next question, and that's, can you explain how providing your specific programs or approaches has helped narrow health inequity gaps or inequity gaps in general? Maybe just talk about that.
I think one of the things is that each organization can look at the service delivery hours. If you look at the newcomers, they cannot come from 9 to 5, and usually clients do not have problems from 9 to 5. Usually they have problems when the agencies are closed, so then they end up at the hospital. So we have to really look at how can we do these things really. And second thing is we have to really review. A woman with 2 small children in -20 will not be able to come to your agency to seek help. Can we have our staff go to her? If we make those small changes, I think we can go a long way. And I just want to be fair to give other people some chances as
well. Well, going back to the language issue, is like you cannot have really good health outcomes if you cannot communicate with your patients. And I still hear people saying, well, you are in Canada, you should be able to speak English regardless. Unfortunately, still very common. But the reality is that there is plenty of research proving that someone that doesn't speak the language or is unable to communicate, that the length of stay in hospitals is much longer, and definitely compliance with treatment, it's not the same, plus the liability of having someone that goes to a procedure without having proper informed consent. So it's beyond being nice for the person that doesn't speak the language. It really affects the entire healthcare system, especially in terms of hospitalization and the duplication in diagnostic procedures. And also, it's a liability for the organizations. So it's a share that everybody should take. It's not just a nice thing to do. It's the thing that must be done.
So the way that my network has addressed some and trying to narrow some of these inequities around LGBT and queer, trans healthcare and mental health care is to really assemble a network of agencies in our region to learn about this, to have expertise, maybe not expertise, but to have some education around how to care for LGBT folks. So my partnerships are about 25 different agencies, including the Halton region, our sexual assault centers, our domestic violence center, our mental health agencies. And so they all have training on LGBT issues and how it intersects with race, culture, food security, all of the addictions that we have, mental health issues that we deal with in our communities as well. And so I do that also by having this network, but I also insert myself and asked to be sitting on different coalitions and different networks within the region. So I sit on, I don't know, I can't even count them anymore, but things like the Halton Suicide Prevention Coalition, right? If you're going to talk about suicide prevention, you need to be talking about the LGBT community, particularly our trans community. And if you're talking about youth engagement, you need to be engaging LGBT youth. If you're talking about diversity and inclusion, you need to be talking about the LGBT community as well.
Thanks, Marcus. For us, most of our stories come from our funded agencies, and so what their agencies report back to us. So it's been about becoming clearer in the questions and the reports back that we ask from our agencies. The other aspect of our work is the collaboratives that we sit on and the project work that we do. So just at the end of 2013, we were involved in delivering 3 mental health focus groups around reducing the stigma of mental health within the South Asian, the Black, and the Chinese community. So that would have been one way that we, again, created the opportunity for residents to come out and have a conversation about this. One of the other pieces would be through our Black Community Advisory Council. We were able to identify that there were not enough mentors within the Black community for Black youth. And so in partnership with Big Brothers Big Sisters of Peel, we were able to create a really unique and innovative partnership that now looks at those approximately 170-something kids that were on their waiting list looking for mentors to reduce that numbers. But it required a conversation. It required a looking at the whole screening process, looking at the training process when you brought volunteers in and identifying them and having an organization that was open and willing to really take that internal look and say, okay, this may be a barrier here, and being willing to remove it. So.
In public health, we offer lots of programs that are universal, meaning that they are open and accessible to everybody, but we know that sometimes programs that are universal in theory don't always translate to being universal in practice. So we're really encouraging people to start looking at the idea of how can we tailor approaches, how can we make slight changes to reach those populations that might not be able to access programs and services without that tailored approach. And we're using the idea of leveling up in order to level up their health to those of the general population.
Thank you. So Erica, you made a comment earlier about how new health equity is or are looking at addressing it. And so my next question really is about measurement, because as we move forward in this, and as many of our agencies start to do it, you kind of want to know, well, are we achieving what we wanted to achieve, and how are we measuring success? And I'm wondering if any of you have examples that you can share of how you are measuring your impact and the success that you've had, and again, give our providers some ideas on tactics that they could use to measure success.
So for United Way, because it's all about demonstrating impact, we have 2 indicators that we look at. One is around accessibility to supports and services and programs. The other one is around community integration. And so within those 2 specific categories, we look at, do people feel less isolated? Do people feel a sense of belonging? Do people have more access to programs and supports once they enter an agency program? And so based on that, our agencies report back. If they identify this as one of their indicators, then there are about 5 or 6 performance measures that they then evaluate their program delivery on. And some may do pre and post sort of testing and questionnaires or surveys, but that information is what we use to indicate, are we moving the needle? Is there a change happening? Do people have more accessibility? Are people feeling more a sense of belonging and feeling a part of the community? And more leadership maybe opportunities or more volunteer opportunities within the community. So we're still fairly new at gathering that information from our agencies and from our neighborhood development strategies, but we just have the first 6 months of data in now, and it's been really pretty encouraging. So I keep saying so, eh? So that is exciting, I mean to say.
I think this, how do we measure? I think it's really important for the organizations to take a critical look at it. The way we measure at Punjabi Community Health Services is, for example, our board composition. If we are located in Brampton and Malton, so our 70% of our board members representative of the community that we serve. So 70% of the population within Malton, Brampton area are South Asians, representatives of the black community and various other communities. Does our board reflect that? And where does the LGBT community fit in? Do we officially identify that that is a community? Do we have young people represented on the board? And I think that's where it starts. The second one is, when we look at the organization's composition of the senior management, is that what is representative? Do these representatives of the community demographics, are they also at the top echelons of the organization? If they are not, then you're not making any health equity impact. If you look at the bigger organizations, and I'm sorry, I just going to be very blunt, but if you look at Peel Regional Police, Peel District School Board, Region of Peel as a municipality, City of Brampton, City of Mississauga, you look at their senior management, the commissioners and the senior bureaucrats, which community do they belong to? And when are we going to stop talking about health equity and actually working towards a solution? Like, I've been in this system officially at Peel Public Health since 1990. For 18 years I was at the system. I wasn't able to change a single thing. Nothing changed at that senior most level. So then it comes to staff. And yes, the changes were made. I do need to acknowledge. So they do hired a couple of South Asian and black receptionists. Now, are we going to say that that is equity? So when we look at measurement of the organizations, the top level has to change. It has to start not from the staff, has to start from management, from the boards that control the organization. If they are not representative of the community, nothing will change.
So recently we had Dr. Joshua Tepper, who's the president of Health Quality Ontario, speak at a G2G session for the Mississauga Halton Lynn. And I think some of you may have been there. And we talked about measuring success, which is great. And I like Baldev's example of how you have that scorecard outside of the ED's office. I know Trillium Health Partners does a lot of that, where you're looking at your results. But Josh was talking about, we look at measures and we celebrate the successes, or we attempt to. But there's great value in also looking at failures. And they're not really failures, but I like to frame them as opportunities. We talk about weaknesses, but really it's an opportunity. So perhaps where we're not doing as well as we would have liked, it goes back to that question that, Keaton posed to us. Ask why. So why is it not that we're not doing as well? And delve into that. Don't just dismiss it and say, well, maybe it didn't work. Why did it not work? Because maybe it is. We still recognize that it is something that we need to do. So, so that's another aspect that we can look at as well. Not just looking at the successes, but looking at measures of how we can improve or the opportunity. So again, lots of experience here, and you've all done many different things. But I'm wondering, as you've moved forward in your organizations, can you talk about a challenge, or what you would say is one of the greatest challenges that you've seen in the organization or community as you've moved forward on the equity agenda? And I'm going to ask not just the challenge, but if you had a mitigating strategy to address that challenge, can you comment on that as well?
Building equitable partnerships with partner agencies is a challenge. It requires enormous amount of time. Smaller organizations may not have the time and the resources to build those equitable. And the word is not just partnerships, equitable partnerships.
I think sometimes the challenge is competing resources. What's a priority? And sometimes you boil down the numbers and you say that percent of the population that needs this service may only be 10%. Is that where we put our dollars or not? And I think, more and more what I'm hearing and what I'm thankful for in something like today is that every person, regardless of how large a percent of the population they make up, deserves the same equal opportunities.
I think another important thing is to identify champions within your organization that somehow can push the agenda forward. Sometimes things, and for what Lisa said, there is so many priorities that sometimes things are not looked at. So if you have a champion that can actually put it at the front of the agenda somewhere, get some people that they can identify within the organization that can champion that health equity piece, I think it's very important.
The LGBTQ topic and issue was very scary in Halton in 1998, and so some of that challenge around people were not listening about how we need to be inclusive of the LGBT community. So that's one of the challenges that I faced. Funding is always a challenge. Who funds LGBT or queer and trans work? One of the other challenges that I think that I face is that in many other communities, this work lies in their CHCs, and Halton does not have the CHC model. So I've always been floating around and having to create my own organization to actually do the work that I'm doing. However, our mental health agency, ROC, Reach Out Center for Kids, now understands how important the work is and has picked me up, and that's been a really great success story to open up more opportunities for that conversation.
Thanks. For us, I think at United Way, part of it is the sometimes internal apathy around discussing the issues and being able to have a real buy-in, not just a sort of a passive-aggressive sort of, yeah, we get it, but, So I think that's part of a challenge. I think another big piece for us, two big pieces, is always having to be mindful and walk a thin line to ensure that donors, because they make our world go around to some extent, understand the work we're doing. So we have to be constantly mindful of not offending anybody. And then the second piece of that is being also mindful of our position as a funder, yet a convener and a community impact. And so with the power to acknowledge, as a funder, we have the ability to direct our agencies, but really want to create a partnership and a relationship of understanding and building community. So we walk a fine line quite often around, this is our role, do we hear, let's step back and reflect.
I would reflect and think that probably one of the biggest challenges is not having great evidence on what are good solutions. And Leanne, you asked us to mention some solutions, and I think that if we really concentrated on sharing our success stories with each other, sharing our challenges, and how we were able to overcome that, I think that would help to create that base of what works. We spent a lot of time doing staff education last spring, I guess it would have been, and we spent a good deal of time doing an evaluation and posting the findings on our website because we knew that others would likely be doing the same. And so if we could share a little piece about what worked, I think that would help.
Can I add one more challenge? Erica made me think about it, is as a funder, we always ask for evidence-based, we ask for stats, we need data, we need numbers. And so we require that. But for our own work to move forward, it's being able to either put the resources forward so the research can be done to collect that evidence and that data for our racialized and the populations across the whole breadth of diversity that we are speaking about. And in many cases, that data is missing. And so that's a challenge for us in wanting to satisfy both the quantitative and qualitative aspects of our work.
And I'll share my own challenge. I think one of the things that I found in terms of raising the profile or bringing health equity to the forefront was just an understanding of what health equity was. Because I always go back to people don't know what they don't know, and people don't necessarily understand what health equity is. And hence I stress the importance of local champions up here, as well as all of you in the audience, because you become the champions for health equity, and providing that knowledge and that expertise and that guidance, and being that champion in your own respective organizations, because I can tell you many do not get it. And it's not because they don't want to, it's just because they don't, or they haven't heard it. And so it is really important that you take that opportunity to be that champion and to educate and advise and encourage. We're going to have an opportunity to talk about the health equity impact assessment tool later on as well. And again, advocating for that and encouraging people and teaching them, because it is a learning curve that people will need to know. And so that was one of the challenges I personally found. And I'm pleased we're progressing. I would say small steps, but it is something that we all need to be aware of. That is a challenge for us to address. So my last question to all of you is, what do you think is the greatest success you are observing in the broader community?
The fact that we're having this conversation. The fact that 20 years ago in Peel, I'm dating myself, but 20 years ago in Peel, the diversity we see there has grown. The idea that we could actually just talk about racism and put it on the table and call it something and say it exists is huge. That LGBTQ communities can actually come out and advocate and lobby within the region and say, this is a huge gap in services in the region of Peel, and that we could acknowledge it just in the broader community, but even within our racialized communities where there's still huge stigmas around many aspects of work. So just being here, actually, today, and having this open conversation is progress at one level.
And just to tie into that, our keynote speaker this morning spoke about working together and working across sectors. So the fact that we have a room full of people here all talking about health equity is a huge success, I think.
So the going back to the video this morning from our guest speaker this morning, the statement that one change in your social determinants of health creates many other changes really resonated with me, because now in Halton we are talking about LGBT inclusion, we are talking about LGBT health equity and access, and so those small changes I've seen in our population, that one small change has made a greater change, so I'm really pleased with that.
I think pretty much has been said already. The fact that we are here, it's a big change. It's really a pleasure, and is a fantastic start.
Yeah, and we've been talking kind of about community and from an adult perspective, but I know I'm hearing it in the education system too when my kids come home and they talk about how they're learning about things as well. So I think that's huge. I know when we were kids, these things weren't talked about, so our educators are doing it as well.
Our agency is located in the Central West Lane, and I was really pleased yesterday we had the Mental Health and Addictions Core Action Group meeting, where two things were presented for future considerations. One was 24/7 services and how we're going to reach there, and the second thing was, is client just an individual or the family? So I think that we are making inroads and successes in a variety of different ways.
So thank you very much. Again, what a great panel, and thank you for sharing all the things that you've been doing to be local champions. I also want to thank the audience. You've been exceptionally attentive, and again, it speaks to the panel and the caliber of the individuals and the work that you're doing. And so, again, for those of you that know me, I'm always about moving to action. And so, as we start to move to action this afternoon, I'm going to ask, as panelists, this is a great opportunity. You don't always get an opportunity to talk to 200 people that are itching to be champions like yourselves. So, if you could leave them with one message on how to go forward, what would that be?
start with the bold.
I think doing something, a lot of times we won't say anything, we won't take action. We're polite, but sometimes just allowing something to continue to exist is as much of a problem as, stopping.
Be patient. Sometimes it takes a while, but don't give up. Keep pushing.
For me, it's conversation. Ask the questions, have the dialogue. Don't be afraid to ask stupid questions, because if you're thinking of it, somebody else is, and it needs to be addressed.
Yeah, I agree with Marcus's. And I think be brave. Don't be afraid. There's a lot of people out there who need your support and need your help. So sort of take the chance and take the risk. But don't fall in the hole.
I think that we all have a role to play in our own little way. So whatever you can do, let's get moving.
Excellent. All great advice. Erica, Sharon, Marcus, Lisette, Lisa, Baldev, on behalf of the group, thank you again for sharing your expertise.